Most importantly, I think one of the reasons that I'm here today is I'm actually a nurse practitioner and I have spent those 15 years that were mentioned in the care delivery system. Started out largely in academic urban medical centers before moving to Basalt, Colorado in 2007 and worked at Valley View Hospital and really had just a tremendous experience with community partners, primary care, and health system partners in understanding what happens in rural communities and how is that different. Both there are needs in both urban and rural, but it was one of the most gratifying experiences I had during my time there. And as I was reflecting on some of the work that has happened for SIM, it reminded me of what I experienced during that time. It was really about community, responsiveness, and resourcefulness. And that is what I've seen in the local public health agency regions that have been funded for SIM, and hopefully I'll talk to you today about. But I just wanted to reflect on that this morning as I was thinking about this talk today. It kind of brought me full circle to the time that I spent in clinical care delivery, trying to make sure patients received the right care and were really able to optimize their health. And of course, fragmented systems, especially between physical and behavioral health, do not allow for that to happen. So what is SIM? Just a brief primer. It's a state innovation model. It's funded by the Center for Medicare and Medicaid Innovation. Colorado was funded $65 million that kicked off in February 2015. The implementation work really started in February 2016. So we've just completed our first full year of implementation. The SIM awards were really meant to drive innovation at the state level, both in delivery form and in payment reform. In Colorado, a robust group of stakeholders led by the governor's office and including all sectors of the state recognized that we couldn't transform our healthcare delivery system without better integrating behavioral health systems and resources with the physical healthcare system. So that became part of our SIM model for the state of Colorado, and we're largely unique. Not all states chose to include a focus on behavioral health integration, and it really shows the drive that this state has, as well as the ears, the listening. Much of our understanding of the needs for our population and our communities comes from local public health agencies, the community needs assessments, much of the data that is being driven. So that was a huge, just kind of coming together of a lot of different partners that recognize things that we're seeing in the community matter, and we need to make sure that we're addressing this, and this is a tremendous opportunity with SIM to do just that. Elizabeth did a great job, and I think Kyle will also talk a little bit about why behavioral health integration, so I'm going to skip over these next two slides just for a minute to talk a little bit more concretely. What is the SIM approach? What is it that we're going to do, or that we proposed, to integrate behavioral health into physical health care in coordinated systems of care for 80% of the population? That is a huge and visionary goal. The only way we could do this was with these following pillars and funding work within each of these pillars to achieve that goal. Practice transformation, really working with the practices to get resources and supports to allow them to be successful in new payment models, but also to understand and better integrate behavioral health into their physical health care setting. Payment reform, we need to start paying for care differently. Population health, and this is new. There was a first round of SIM states, and they did not have funding in the population health realm. So we were really one of the pioneer states that was able to galvanize from much of the energy around the ACA and the funding for public health and understanding how does public health and health systems, how can we start bringing these two systems together. So I'll talk a little bit about our population health funding. As we all know, so much of health happens outside of the healthcare setting. So much of the resources, the supports, the trust, and the relationships happens in the community. So this is really our opportunity to do just that and connect that with the work we're doing in the healthcare systems. And then health information technology. We know EHRs and interoperability is not going away. How can we effectively share data to make sure that we're more effective and efficient with our care? So I think Kyle has this, sometimes we steal slides, I'll say, but he has a similar slide. This is just a little bit of a snapshot of what are the resources. Within the practice transformation pillar, we have two different bodies of work. By far the largest area that we're funding for SIM is the practice transformation work in primary care practices. And I talked to two at my table today that said that they had applied for our second cohort of primary care practices. Our application closed in the late spring, and we're hoping to announce in the next few weeks here. So that was really exciting to hear. Just to recap, for our first cohort of practices that kicked off in February of 2016, we had 100 primary care practices. This next cohort that we'll announce in the next few weeks, we will have 165 primary care practices. And what do the practices get? What are the resources and supports to help them be successful? This pinwheel is meant to really reflect the resources that are available for practices. And I'm not going to spend a lot of time because I think we'll hear a little bit more about this from Kyle, but it just shows the robust and kind of intersecting and complementary work that the practices have access to. One of the key things are the three people in the middle. Those are the important roles that will touch a practice, that will partner with that practice to make sure they can utilize all of these resources and be successful. The practice facilitator and the clinical health information technology advisor are largely clinic focused. But we'll talk in a little bit about the regional health connector role, and that is a new workforce that's being developed as part of SIM as well as another initiative. They are now deployed statewide, and they're working very closely with local public health agencies, and so that's kind of the connecting point to a lot of the work that's happening in the communities. So just to give you a sense, and sorry I don't have the updated with the cohort 2 practices, but happy to send that out once those are announced. For our cohort 1 practices, to give you a sense of where we're touching in the state, you can see that we do have, certainly we're largely in that I-25 corridor, but we have a lot of practices that are dispersed across the state, and that's very important. We had a quota for the number of rural practices. We wanted to make sure we had a robust presence of rural practices as well as pediatric serving practices. So we're pleased to say that the second cohort continues to show a pretty wide distribution across the state, and that is exactly what we want to see for the SIM initiative. So we're going to hear a lot about behavioral health integration in the practice and why it matters and how can it be done successfully. And we've learned a lot in the first cohort working with practices in the last year. You saw that they were dispersed pretty widely. They were also some of the more advanced practices in the state. They were the ones that were out front willing to sign up for an initiative without knowing exactly what they were getting into because it was our first cohort. And it was interesting to really learn together about behavioral health integration on a large scale. This is a diagram of their self-assessment on where they were along the continuum of integration. So there are different kind of components that move you along that continuum of integration. Of course, fully integrated care is having a behavioral health provider on site who's able to do some of the things Elizabeth mentioned with the warm handoff, stepping into a room, non-billable interactions with patients. What we found, in addition to looking at this assessment, but also what we found from hearing from some of our practices and some of our payer partners, was that this was hard for some rural communities. How can you staff for behavioral health integration when you can't get the workforce or you don't have the population to support that workforce? What are some ways to be effective within different settings and within different populations of need? So that's definitely something we've been working through for the second cohort. Again, I think we'll hear about some of the solutions today from all of you, but that's absolutely something we heard is there are different ways to be successful at integrating, and our goal is to make sure you have the resources to do it in a way that fits your population, but is also sustainable. Want to mention for sure that in addition to the total of 400 practices we'll sign up by the end of SIM, we do have 4 bi-directional health home sites, and these are community mental health centers that have embedded a primary care provider within their setting. These centers are not southeast is down in La Junta, so that's really our most rural center, otherwise a little bit more in the urban space. But we're really learning from them about the integration for individuals, most often with serious and persistent mental illness. How can you make sure you're getting them the right care at the place they choose to call their medical home? So now I'm going to just talk a little bit about the population health pillar, which I'm so excited about. As my bio mentioned, I was at CDPHE and was part of the RFP drafting for this funding opportunity. And really the excitement around being able to fund communities to span the work from stigma reduction, behavioral health outreach and education to better understand in the community from partners that know that community, to starting to develop or strengthen those linkages with health systems, because what's often missing is a health systems understanding of the resources in the community. And so trying to open up those channels to make sure we're really maximizing our resources that are available. So as Elizabeth mentioned, there were two main focus areas that we were looking for: the behavioral health promotion, outreach and education, stigma reduction, which has been just a huge value. And we've already seen a lot of exciting things come out of our LPHAs, and then that coordination of systems. This just has an example. Jefferson or Tri-County Health Department has released the Let's Talk Colorado campaign, which is a stigma reduction campaign, and you're welcome to access this and see what they say. One of the things I wanted to mention here, earlier I was talking about things we had learned in the last year with the integration and how it looks different for urban and rural and different level practices. One of the things that we have seen from the local public health agencies that are funded is they're also creating a space to be nimble and understand the evolving needs of their community and what's really the right things to invest our time and resources. And Elizabeth, pointed to the two top, I would say statewide from the governor's office to community level concerns that we have in the behavioral health space: our suicide rates as well as our opioid use in the state, and how can we use these dollars to connect with all of the other work happening in that space. So it's been great to see how communities are really making sure this funding is of value and continues to serve the needs of the community. So I do want to call out our URA Public Health as the lead agency. What was really exciting in this funding opportunity was to see the different regions come together. One LPHA might be the host or the lead agency, but all applicants came with partners that said, we recognize they're the lead, but we are in this with them. We want to do this work. We have natural partnerships or shared populations. And so we were coming to the table together, and this has been a tremendous just reflection on the continued sense of community and resources and coming together. These partners that signed on and are still partnering with URA in some way or another, many are here today for this very reason. And so that's exactly what this funding was meant to support, because we know it was already happening. Certainly SIM didn't create regional partnerships, but the strength of those partnerships hopefully has been enhanced through this funding. So now I want to just briefly talk about the Regional Health Connector role, which, as I mentioned, was a new workforce, and it really was created with this vision and understanding that we have a lot of community resources, we have a lot of things happening in the health systems, but we're still lacking that capacity to connect the two of those things. Certainly, leaders in this space have been many partners in our rural areas of understanding how do you use resources effectively, but nonetheless at a statewide level we recognized a need to develop some capacity building in this space. So the Regional Health Connector is really meant to connect at the system level. This is not a patient level role. This is a system level, connect the community with the health systems and the practices. Be that linkage and understanding the needs driven by community data and community assessment, but also understanding where are the gaps that the practices are identifying. So this is a complementary role to much of the work that LPHAs will be doing. The regional health connectors were chosen by the host agency. So applicants could apply, and there's one regional health connector in each health statistics region. So we have 21 regional health connectors across the state. Of course, we recognize we wish we had 500, but we have 21 to start. And the host agencies that have been funded are across the board. Some are AHECs, some are LPHAs, some are nonprofit organizations. I think we might have a health system, I'm trying to remember. But it really shows, that, again, communities come together to say, this is the organization that we think makes sense. They have a robust understanding of community needs. We think we could staff a person to do this work within this organization and start to better strengthen some of those connections. So this work is being overseen by the Colorado Health Institute, and happy to talk more at the break or in the future, but it's definitely kind of a connector role. They'll be working with many of our SIM partners, both in the practice as well as the local public health agencies. So just wanted to, I keep looking at, I don't want to go over. How are we assessing our work for SIM? I talked mostly about the practice transformation work and the population health work. I'm not going to spend a lot of time on the payment or the HIT today, but we have a pretty robust evaluation and metrics that we're tracking to assess, are we moving the needle? Are we really improving health because we're focusing on behavioral health integration and better connecting those systems both within the community but also within the practice? And a lot of the population health data won't be a surprise to population health people in the room. It's largely BRFIS or child health survey data. The clinical quality measures for our clinicians and practices in the room, many of these measures are measures that you may be held to as part of the Medicare program. We've certainly done a lot of work to align our measurement and requirements to existing requirements that practices might be held to. And then we've got a lot of cost and utilization, access to care, and some overall, how are we doing in terms of consumer and patient satisfaction? And that data will be now that we're done with our first year, we'll start seeing some true comparison data, which we're looking forward to. So just to reinforce that the delivery system and the population health are really the two main funded areas. The cost of care utilization, that's equally important because we know that integration is the right thing to do, and it enables whole person care and can really allow the individual to just receive the right care at the right time. But we also know that untreated behavioral health is a significant cost driver in our healthcare system. And that's certainly something that our health plans and payers that are participating in SIM are interested in. We have 7 payers that are participating and supporting our SIM practices, and they're all looking at cost and utilization. So we want to make sure we are too, and that we're helping our practices to use that data and actually access that data as well so they can be successful. So this is just going back to our clinical quality measures. That was the first column a couple slides ago. We had a really robust response, which clinicians, practices in the rooms, I think you can appreciate how hard it is to report clinical quality measures, significant barriers in workflow, working with vendors, getting the data out, data quality, data trust. Those are all things that we're very much aware of and working with our practices through the clinical health information technology advisors. And it was a tremendous showing by the end of our first year that our practices were able to significantly improve their reporting of data. And I'm sorry, I actually have a slide of what the results were, and I apologize, it didn't make it in here, but I could send that out afterwards if you're interested in seeing. One of the things we're actually going to do in the near future is start looking at our clinical quality data and some of our BRFIS data, and how does that relate to each other? How does our population or county level data compare to the work that's happening in practices? Just to start noticing if there are any trends or anything that we can speak to. We do have a data hub on our website, and it's accessible there as well, so I can make sure these slides go out afterwards. Lastly, just to kind of bring it back home for anyone who's interested in participating other than how you might be already if you are, we do have a pretty robust work group and stakeholder process. We have 7 work groups that participate to inform SIM, including the practice transformation, policy, evaluation, consumer engagement, workforce. I'm going to forget. This happens to me every time. They're all important. Evaluation, and I'm going to can't remember what I said, but I'll make sure you guys have a list of that. And what's important is we really have partners across the state that come. So many people from outside of the Denver area, of course, are on the phone and webinar, of course. But we have pretty robust participation in these work groups, and invite you, if you're interested. It's on our website when they're on, and it's a pretty good opportunity to really work through some of the practice, community challenges, and policy issues that are rolling up because of this initiative.